Well, this evening, we're delighted to have Dr. Marshala Lee, MD, MPH, who currently serves as the Harrington Trust Physician Scholar and Director of the Harrington Value Institute Community Partnership Fund. Dr. Lee completed her residency in the Department of Family Medicine at the University of Maryland Medical Center in Baltimore. She has focused on health disparities, especially those related to cardiovascular disease. A Jackson Heart Study Scholar during 2007 and 2008, Dr. Lee served as principal investigator in training in the Know Your Numbers campaign, and her 2005 research for the Jackson Health Study was entitled The Effect of Oral Contraceptive Usage on Cardiovascular Functioning in Participants in the Jackson Heart Study. She also co-founded Power Kids, a childhood obesity program. During 2005, Dr. Lee was a University of Washington Multidisciplinary International Research Training Program Fellow, and she received her medical degree with a concentration in advocacy and activism from Brown Medical School in Providence, Rhode Island in 2011. Dr. Lee, over to you. Thank you for joining us.
Tim, I hate hearing all about that stuff, so thank you for the warm introduction. It is definitely an honor and a pleasure to be with our audience today. Kudos to you for hanging in here for 6 sessions. I have big shoes to fill, but I hope that you leave today with some information that allows you to be a better advocate for health equity. So thank you for tuning in today. I hope you enjoy it. Today, I will be talking about racism in medicine. Did you know that African Americans have higher death rates than white and the 15 leading causes of death? Black and Native Americans have higher age-specific death rates than whites from birth through the retirement years. Minorities get sicker sooner and have severe illness and death sooner than whites. Hispanics have higher death rates than whites for diabetes, hypertension, liver cirrhosis, and homicide. These are a few stats from one of my professors at Harvard, Dr. David Williams, who is a world-renowned historian on the effects of racism in medicine. In 1980, the United States was 11th on life expectancy compared to the rest of developed countries. In 2014, we have fallen to 35th in comparison to our neighboring countries. US ranked behind South Korea, Greece, Cyprus, and a few others. It is not just minorities that are doing badly. In 2014, white America, if you separated them out, would be 34th in world rankings. In 2014, if you were able to separate Black Americans, we would be 96th. That is a shame. I'll spend a little time talking about social determinants of health. This is a relatively new concept, and I want to make sure that you understand how it affects health disparities. Social determinants of health are the conditions in which people are born, live, work, and grow, and age. It also includes the health system. Social determinants of health are the economic and social conditions that influence the health of individuals, communities, and countries. These circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. Social determinants of health are typically categorized into 5 domains, which include education, social and community contacts, health and healthcare, neighborhood and built environment, economic stability, and education. Challenges in one or more of these areas can impact an individual's health. This slide highlights some of the factors that exist within each social determinant of health domain. These factors can either positively or negatively influence the personal behaviors and the levels of toxic stress that influence and have an outcome on people's health. We will come back to this later in the presentation, but as you can see, racism and discrimination and historical injustices reside within the social and community context domain. Health disparities are largely a result of social inequities. Health disparities occur when a population faces a disparate burden of disease and illness. As I mentioned on the previous slide, that housing is a social determinant of health. Environment, where you live determines access to high quality schools, job opportunities, safe, affordable and healthy housing, fresh produce and nutritious food, safe exercise spaces, walking or the ability to play outside, toxins from highway, factories, and other environmental hazards, quality primary care and good hospitals, affordable, reliable public transportation, and social cohesion and social capital. All of these are important social determinants of health. Housing and where you live matters a lot. This slide is an illustration of how life expectancy can vary within a matter of miles. This picture was taken from, this image is from New Orleans. But as you can see, populations that are historically comprised of more African Americans closer to the French Quarter, which were also the areas that were most ravaged by Hurricane Katrina and the 7th Ward, they have much lower life expectancy than other populations that are predominantly white. And these are a matter of miles. I could have shown a similar image of Delaware, but we know that different zip codes within Delaware, such as those that are within Wilmington, 19802, 19805, have much higher disparities than other zip codes that are predominantly white. So housing and where you live matters a lot for your health. I'm going to share this video from another renowned scientist, Dr. Kamara Jones, who was the past president of the American Public Health Association.
I'm Dr. Kamara Phyllis Jones, past president of the American Public Health Association. You may have heard the saying, an ounce of prevention is worth a pound of cure. When it comes to health and well-being, preserving health is always best. But there's more to the story. Imagine that someone is walking along and whoops, they have just fallen off the cliff of good health. And if that were you, you'd be relieved to find an ambulance at the bottom to speed you on to health care. But what else can we do to protect you? How about a net to catch people? But nets have holes, so some people may still fall through, and the net is likely to rip over time. What else can we do? Clearly, we need to build a fence at the top of the cliff to keep people from falling in the first place. But if a lot of people are near the edge of the cliff, even a really strong fence will not be enough. To keep everyone safe, we need to move all the people away from the edge of the cliff. We do that by addressing the drivers of poor health that go beyond our genes and beyond our personal behaviors. Things like low wages and under-resourced schools and unsafe housing. The environments in which we live, work, and play shape our health. These are the social determinants of health. These things can either propel people toward the cliff's edge or keep them at a safe distance from it. But this cliff analogy is incomplete. We need to also realize that the cliff is really three-dimensional, and then to notice that resources and people are not evenly distributed along this cliff. At some parts of the cliff, the ambulance at the bottom may have a flat tire, or maybe there's no ambulance there at all. Maybe there's no net, nor fence. And usually, at those parts of the cliff, the people are being pushed closer to the edge. These are the differences that lead to health disparities in a population. Differences in the speed and quality of the ambulances represent differences in quality of care. Differences in the presence of ambulances, nets, or fences, these represent differences in access to care. And differences in the distance to the edge of the cliff represent differences in the opportunities and exposures and stressors that make some people and communities sicker than others. We need to ask a lot of questions. Why is the cliff three-dimensional? Why do some parts of the cliff lack ambulances or nets or fences? And why are some people being pushed closer to the edge? It's because our economic system fails to provide an even playing field. It's because racism, which is foundational to our nation's history, is still with us and continues to cause profound harm to us all. And because discrimination against people of color, women, immigrants, the LGBTQ community, poor people, and others holds back our nation's health and well-being. Everyone should have the opportunity to achieve good health. If we try to address the social determinants of health without tackling these bigger systems of structured inequity like racism and sexism, we risk moving some people away from the cliff's edge, but not others. We risk making health disparities worse. Experts at the Urban Institute are exploring how local, state, and national policies have gotten us to this point, and what policy solutions inside and outside the healthcare system can drive fundamental improvements in health and well-being for everyone.
All righty, I will stop the video there, but I recommend you researching her work. She has a lot of great stories and breaks down racism in a way that's easy to digest and to explain to others. But really her allegory for the cliff of health, she also has a story about the gardener that talks about how implicit and explicit individual biases and racism can affect the outcomes and health outcomes. So I recommend both of these stories. Now it wants to play within. She described health disparities, but again, I want to make sure that everyone understands the language that we're using. Health inequities are differences in health status between more and less socially and economically advantaged groups. They're caused by systematic differences in social conditions and the processes that effectively determine health. Health inequities are avoidable, unjust, and therefore are actionable. That's the good thing. We can do something about it. Dr. King, one of his famous quotes that a lot of people don't know about, but I knew about it at an early age, growing up in the Mississippi Delta. He was a big advocate for social justice, but he spent time also advocating for health inequities because he made the link at an early time, even before we were highlighting social determinants of health. But he said of all of the forms of inequality, injustice in healthcare is the most shocking and most inhumane because it most often results in death. And so this is something that has been on the forefront and foremind of civil rights workers, but unfortunately in the last decade, we've now been paying more attention to it. So I'm glad that you're here today, and we have a lot of work to do, but have made a lot of progress since Dr. King made this statement in the 1960s. Social inequities, such as the social determinants of health, lead to social inequities, also known as disparities. Disparities are the differences in the incidence and prevalence of health conditions and health status between groups based on race, socioeconomic status, sexual orientation, gender, disability status, and geographic location. The reason why it matters because we don't want to treat people differently, but it matters to all of us because health disparities lead to increased healthcare costs, as well as higher mortality and morbidity, and shorter life expectancy for our neighbors and community members. And so this is another diagram of how do health inequities occur. Directly in the healthcare system, health inequities result through inequities. So there can be inequities in exposure and opportunities, as we mentioned, gun violence, having more risk to environmental hazards, access to health. We know that certain communities have poorer access to health, or when they do access health, the quality of healthcare in those establishments is less than others. And when we're looking at present day and looking at present day disparities, we're plagued by past injustices and inequities, as well as current injustices and inequities. So it's important that we include that in the discussion as well. The impact of stress in our lives is well known. We know that increased stress from social inequities can lead to higher cortisol levels, which increases your risk of cardiovascular disease and diabetes. These stress levels are higher in people from underserved communities, which typically are higher represented from minorities and people who have been historically marginalized. All of these things are known to increase not only those chronic diseases that I mentioned, but they can also have epigenetic effects on our genes, which can be passed down to generations. So we know that stress can impact not only your chronic health, your current health, but the health of future generations. And that's one way that we explain why minorities have poor health outcomes. We also know, I'm taking you back to high school science, that stress impacts the length of telomeres, which are the sequences of DNA at the end of your chromosomes. The telomere length is viewed as an overall marker of biological aging. Studies have found that Black women have shorter telomeres than white women. And this is at the same chronological age. Black women had accelerated biological stressors. And so all of this are effect of chronic stress. And so not only do we know about its effect at the chronic disease level, but also at the genetic level. And we have research that has proven this effect. Health and racism, that's what you came to hear about. And so I'm going to try to explain how our health disparities can be explained by historical and current racism. Oftentimes, we identify health disparities and we want to leave it there without discussing the elephant in the room. So what caused those health disparities? Were Black people just born less healthy than white people? No. Are we genetically different than whites? No. We know that we're not born differently. More research is needed to understand the effects of genetics and race, but we know that race is a social construct, a term that was used to really describe and justify slavery. But we know that race and ethnicity are not the same, but we do know that certain genes are more common in different minority groups and different ethnic groups. But even within those differences, they do not in themselves explain the social, the health outcome differences that exist between groups, racial and ethnic groups. I want to clearly define these terms because language matters. And so we'll spend a little time here. Race is a socially constructed concept that was really used to reinforce the rationale for the enslavement of persons of African descent. Racism is prejudice, discrimination, or antagonism directed against a person or people on the basis of their membership in a particular racial ethnic group, typically one that is a minority or marginalized, and the power to exert said prejudice, discrimination, or antagonism. They must have power within that group. The development of racism is typically undergirded by an ideology of inferiority in which some population groups are regarded as being inferior to others. This leads to the development of negative attitudes and beliefs to racial outgroups, prejudice and stereotypes, and differential treatment of these groups by individuals and social institutions. The trauma of racism is the cumulative adverse emotional, psychological, health, economic, and social effect of racism on the lives of people of color. And so racism really lives on a spectrum. Oftentimes we focus on internalized racism and interpersonal racism. That's really the micro levels of racism. So the one-on-one, so internalized racism are the thoughts that people have within their, in their brains. But when they allow their thoughts to influence actions, that becomes interpersonal racism. Institutional racism is the racism, the practice and the cultures that exist within companies and businesses. The accumulation of those differences in racism that exists within institution forms structural racism, which we know is a lead determinant of health. And those structures are really what we now call the social determinants of health, which we know are really a product of structural racism. In many ways, COVID-19 was the perfect storm for structural disparities. African Americans and Indigenous Americans have the highest age-adjusted death rates compared to whites. And we know that those COVID-19 health disparities are resulting from a combination of structural racism as well as institutional racism. So we know that African Americans and other racial and ethnic groups that have higher COVID-19 mortality and incidence rates were more likely to have increased exposure. This was due to a higher rate of being on the frontline occupations, residential crowding, public transportation, and poverty. Many of these circumstances are a result of systemic racism. Going into COVID-19, many racial and ethnic minority groups had higher rates of chronic disease disparities, such as diabetes and hypertension, high blood pressure, which we also know are risk factors for poor COVID-19 outcomes. We are shining a light on the institutional racism that has existed within medicine and our healthcare system, because we also played a part in the COVID-19 disparities. Early on, we know that there were testing and treatment disparities that existed that resulted from unequal access. So depending on where our hospital and testing locations were, some communities had less access to testing and treatment. Affordability and health insurance gaps. Early on, many people were concerned about their ability to pay for COVID treatment, so they delayed going to the doctor. I'm thankful now that COVID-19 treatment is available for free, but it was a communication challenge because many people had histories of large medical bills and didn't want to burden their family. That was an early factor in the COVID-19 mortality disparities. We know that provider bias and racism, not only do they affect COVID-19 treatment, but they affect the clinical care that we provide. I'll describe some other well-known instances where provider bias and racism has been well researched and studied. History has caused a lack of trust and stigma, not only just historical injustices and in historical things that have happened in medicine, but many communities have had real lived experiences of unfortunate interactions with their doctors and medical providers. That has led to a lack of trust and stigma, why many people really are hesitant with getting vaccinated. And miscommunication. We're working to improve health literacy and cultural competence so that medical providers, regardless of their race, are able to have productive conversations and trust with their patients. All these factors have led to higher COVID-19 incidence and mortality among minorities.
Dr. Lee, can you explain what you mean by age-adjusted death rates, please?
Yes, so age-adjusted death rates. So we know that, I have a slide that's coming up. We know that life expectancy for whites is much higher than Blacks. So for instance, life expectancy for white women is in the 80s. And so for Blacks is much lower. And so if you're comparing death rates, you can't compare the death rates within populations to each other if they have different life expectancy, because we know that aging in itself is a risk factor for dying. So the older that you are, the more likely that you are to die. And so we know that even when you match, so there's a way of matching within statistically of what we do to be able to compare populations to each other, even if they have different average death rates. And so what we know is that, for instance, let's say a Black woman who's 50, we compare her to a white woman who's 50. The Black woman still has a higher likelihood of dying from COVID than that white woman who's 50. So it's really a way to compare populations despite there being differences in the life expectancy between those groups. I hope I explained that well enough, Kate.
It worked for me. Thank you.
Okay, and this slide is a slide that really explains what the average life expectancies were prior to COVID and after COVID-19 for different populations. So the average life expectancy for Hispanic Americans was almost 82 years in comparison to 79 years for white Americans, and Black Americans' life expectancy was 75. So almost a 4 to 5 year difference on average between Black Americans and whites, and then almost a 7 year difference between Black and Hispanics. But as you can see, for all populations since COVID-19, the life expectancy has decreased. So life expectancy is how many years a person can expect to live if you compare a baby that was born in 2019 versus 2020. So it's a way that we compare the health of nations. So from this slide, overall, the life expectancy for all Americans decreased, but the life expectancy for Black Americans decreased more than other racial groups. So for a Black man, since COVID-19, the life expectancy has decreased 3 years because there was a higher rate of Black Americans that died from COVID-19. But this was the first year, I forget, Kate, in how many years the life expectancy actually decreased. So we were doing very well prior to COVID, but COVID has significantly reduced the life expectancy for many populations, but more so for Black Americans. And despite the differences in life expectancy, so the groups that have been most affected by COVID-19, they are the most likely to not get vaccinated. And many people are like, that doesn't make sense. Why aren't they running out there to get vaccinated? But that's where historical injustices and the lack of trust and stigma come in. And we know that those are major factors impacting the rate of people getting vaccinated, especially the disparities in the rate of vaccinations that exist within Black communities. And so you can look at current disparities without understanding the historical context that got us to where we are today. And so we know that slavery occurred from 1619 to 1865, but even after slavery was outlawed, there were structures of racism that were put in place to maintain white supremacy. Post-emancipation, there were structures of racism that were also put into place to maintain white privilege. During the 1960s and prior to then, post-emancipation, there were Jim Crow laws, segregation, redlining that targeted Black people. There were also racial bias and justice that still exists today. There is, all of these things have resulted in concentrated poverty and social determinants of health inequities that have led to poor access to healthcare, poor housing conditions and physical environments, poorly funded schools, and poor access to health and to capital. And so this is really a diagram that shows how history has led to the social inequities that we see today. Any questions? Okay. So racism in medicine, I want to give you a few specific examples of racism in medicine. During the colonial period, owners would hire out or sell slaves to physicians for use as guinea pigs in medicine and medical experiments. So I hear a lot of patients saying, I don't want to be a guinea pig with that COVID-19 vaccine. Unfortunately, African-Americans, Black slaves were guinea pigs in medicine, and it has been well documented. During the 19th century, Black cadavers, so those are the what we use in medical school to the deceased bodies that we experiment on and we learn about medicine in medical school, were routinely exploited for profit by whites who shipped them to medical school for dissection and to museums and traveling shows for casual display. And so their bodies were used in medical schools without permission from the families. Dr. Marion Sims was a 19th century gynecologist and was only able to achieve breakthroughs by performing horrific surgeries without anesthesia on his female slaves. He was oftentimes referred to as the father of medicine, the father of OB. And this is an image of him with one of his slaves, a depiction. He was known to, again, conduct surgeries on his slaves, different gynecological surgeries without anesthesia. So these are real traumas that we know too well. And so medicine in itself had some racist tendencies. So the AMA, which is the American Medical Association, actually published the Directory of Physicians in 1906. And unfortunately, they listed Black physicians as colored. Prior to this, many Black physicians were practicing in their communities. They were able to access capital from banks who didn't know their race. But after the Directory of Physicians was produced and labeled those Black physicians as colored, it made it more difficult for Black physicians to obtain malpractice insurance and credit to run their businesses. So some more historical encounters of racism in medicine. Many people know about the Tuskegee syphilis study. In that study, 600 men who contracted syphilis were left untreated by the U.S. Public Health Services so that it could study the progression of the disease. So I like to explain that in 1932, when the study started, there was not a treatment for syphilis. The U.S. government did not infect these men with syphilis, but once they contracted syphilis and we knew that penicillin was an effective treatment, they withheld penicillin so that they could study how syphilis would manifest in Black individuals. They were allowed to die untreated so that their cadavers could be used for research. And oftentimes, unfortunately, it was the Black nurses and doctors that were put on the front line to interact with these patients. And they had a lot of trust and faith in those Black doctors and nurses. And unfortunately, we didn't treat them well. And so that's why it's not only many patients that don't trust white doctors, but many patients and community members don't trust Black doctors either because of these historical injustices. During the 1960s and early 1970s, brain surgeries were performed by the University of Mississippi, where I'm from. They were done on African-American boys as young as 6 who were deemed to be aggressive or hyperactive. It was also conducted as a procedure. It was also recommended as a procedure by the medical community that should be done to study the brains of urban rioters after the Watts. So this is recent memory and recent ways of how medicine and physicians have upheld racism. And unfortunately, this has led to significant mistrust in the medical system. This picture is a picture of the former President Bill Clinton and the Surgeon General, David Satcher, to his left, but the men in the wheelchairs were actual survivors of Tuskegee. So it's very unfortunate that they didn't receive an apology from the US government until President Bill Clinton came into office. So these are very recent historical injustices that are known to our community. Medicine in the civil rights movement. I wish that doctors in medicine were on the right side of history during the civil rights movement, but the majority weren't. The picture to the left is a picture of how not only was there segregation in hospitals, but Black doctors were mistreated in medicine and were often barred from practicing in majority hospitals. The picture in the middle is the medical community for civil rights. There were some doctors on the front line that were fighting to erase racism in medicine, but unfortunately, the majority of hospitals at that time were segregated, and the system of racism was being upheld by our hospitals. Hospitals were not integrated into the passage of Medicare by the federal government that barred segregation in hospitals. So they were forced to integrate their hospitals if they wanted to continue to receive federal funding. But as you can imagine, those thoughts and beliefs of racism didn't disappear overnight. And we're still plagued by some of those thoughts and some of those practices. And so we have a lot of work to do to heal the wrongs that have plagued medicine. I want to spend a little time talking about implicit bias. I really talked about more so structural bias on those previous slides, but implicit bias are internalized and implicit racism. So that's the micro levels of racism that we know have an important impact on the trust and outcomes of our patients. Implicit racism and biases. Everybody has biases, and in many ways, they are a protective mechanism. They are normal, natural, subtle, and often subconscious. They are universal. All humans have them. They are developed naturally through routine social interactions and exposure to the media. So that's why it's important to have a diverse representation of friends and not rely on TV and the media, because it can lead to biases. They guide our expectations and interactions with others. They can become harmful when assumptions and generalizations about our group affect our interactions with individuals. Even the most well-meaning individual can harbor deep-seated bias. So it's important that we are aware of this and work actively to overcome our biases. We know that biases happen faster than a blinking eye. Studies find that most Americans have rapid and unconscious emotional and neural reactions to Blacks. A millisecond is 1/1000 of a second, so a very short period of time. Within 100 milliseconds, research has shown That's about how quickly it takes for an individual's race to be noticed and whether or not the person is trustworthy. Within that short period of time, people can make that judgment. Within 300 to 400 milliseconds is the time for the human eye to blink. So faster than someone's eyes blinking, they've already made judgments about people based upon their race. And within 800 milliseconds, that's the human resting heart rate, heart cycle time. So biases occur very quickly. So you must work really hard to overcome them. They matter because they can affect the care that's provided to patients. This research study evaluated the percentage of patients that were given pain medication when they presented to the hospital with a broken bone. In this study, unfortunately, 55% of Hispanic patients were not given pain medications when they presented to the hospital with a broken bone, in comparison to 26% of whites that were not given pain medication. And you wonder, why does this occur? Studies have shown that, have researched the empathetic gap. And we know that empathetic responses and brain activity differences occur when viewing suffering of persons of one's own race versus members of another race. We know that stronger empathetic neural responses to the pain of the same race occur typically stronger than when they are evaluating the pain of someone of a different race. And this has been studied using a variety of different stimuli. We know that implicit bias also matters because it can result in differences in health outcomes. A study of 1.8 million hospital births in Florida between 1992 and 2015 showed that Black babies were 3 times more likely than white babies to die in the hospital. And so some people would say, okay, well, maybe it's those social determinants of health acting up, and that's the cause for it. But we know that that disparity was cut in half. So those same babies, their likelihood of dying was cut in half if they were cared by a Black doctor. The biggest drop in deaths occurred in hospitals that care for more Black babies. There was no difference between the doctor's race and maternal mortality, unfortunately. So we know that the race of the doctor can impact the health outcomes of the baby, but that has not shown to be true for affecting the health outcome and status of the mother. So there is definitely more research that needs to be done to determine why there's differences in maternal mortality rates between race. And some people would say, okay, well, Black babies should just be cared by Black doctors and everything would be okay. Unfortunately, despite African Americans comprising 13% of the population, we comprise less than 5% of the population of doctors. And this number has not changed much since the 1960s. So we have a lot of work to do. And we can't rely on Black patients being cared for Black doctors as a solution, but we must work and address the implicit bias and the other factors that are resulting in different health outcomes and different treatment levels for patients that are cared by doctors of different races. I've shared enough bad stuff. Hope you're not depressed. But there is some good news, as I mentioned. Since racism is a social construct, we can deconstruct it and work towards health equity. Health equity is the attainment of the highest level of health possible for all people. Achieving health equity requires valuing everyone with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health disparities and healthcare disparities. So, as I mentioned, there are a number of factors that result in health inequities. Clinical care is a necessary but not a sufficient condition for equity in health outcomes. So in the medical community, I'm working with my colleagues to overcome our implicit biases, because we all have them. But we are also working to improve the conditions that exist within our communities, because a comprehensive approach is going to be necessary to achieve health equity and to overcome the historical and current injustices that have existed. I'm thankful at our hospital, Christiana Care, our CEO, Dr. Nevin. She has made it a priority to address health disparities and racism. She put out this statement last year, which said, "We will work to overcome and eliminate systemic racism and create a healthier, more equitable Christiana Care and community together." And I'm really thankful of the work that we're doing as a system to improve not only the health of our communities that we serve within our doors, but also to address those social determinants of health. And so this is a summary slide, and I hope you receive some of these points from my presentation. Inequalities in health are created by larger inequalities in society, of which racism is one determinant. Health inequities are problems of racism, and not problems of race. To achieve health equity, we must first name and identify structural racism in places it exists, and then challenge and dismantle the structural racism that shapes upstream governance, social structures, and policies that perpetuate ideologies of superiority over historical marginalized populations and perpetuate persistent disparities. Systemic change is needed to dismantle structural racism. Future policies and interventions must be implemented at the individual, community, and population levels to achieve equitable access to social and economic resources that enhance health equity for all historically disenfranchised groups. I want to leave you with this call to action from the late Congressman John Lewis. It's easy to get overwhelmed, but he said, "Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year." Racism didn't occur in a day, month, or year. It is the struggle of a lifetime. Never ever be afraid to make some noise and get in good trouble, necessary trouble. So I'm going to ask you all to help me get into some good trouble, some necessary trouble to overcome racism and its impact in health. I want to leave you with some further readings if you are very interested in this topic. Unequal Treatment, it was a publication by the Institute of Medicine that really delved into racial bias in medical care and provided a lot of data to support the understanding of racism in medicine. This book by Harriet Washington, Medical Apartheid, provides a comprehensive history of medical experimentation on Black Americans from colonial times to present. Jim Downs recently released this book, Sick from Freedom, which describes African-American illness and suffering during the Civil Rights and Reconstruction and how the social environments really led to those disparities. And Dr. David Williams and Dr. Cooper, they have Reducing Racial Inequities in Health using what we already know to take action. So really, again, a call to action. And we know the tools and resources that work, what we need to do to overcome racial and ethnic disparities that exist in medicine. And so I thank you for your time, and together, I think we can stop racism. I look forward to your questions. Thank you.
Thank you, Dr. Lee. That was a fantastic presentation. There are a couple questions in the chat. The first one is, has anyone looked into changes in demographics in doctors' practices when they change from a model of accepting all patients to a boutique or concierge retainer practice or membership medicine model like as MDVIP?
That's a very packed question. A lot of doctors are against those boutique models only because you can imagine the patient demographics that are able to afford boutique medicine typically are patients that are more well off. And so even the patients, it's hard to compare apples to apples because typically even if Black patients are able to afford those boutique models, they are more well off patients. So you can't compare the outcomes of patients in those models to the outcomes of patients in your general practice. I'm not sure if I answered your question correctly, but there hasn't, my understanding, been a comparison study of those two practices, largely because those social economic disparities that may exist between comparing those two groups.
Thank you. Next question. How has the life expectancy changed for a baby born in the last 2 years if COVID shouldn't affect them in their adult years because we're aiming for, quote, permanent vaccine?
So that question is a great question, and is one of the problems with public health and sometimes the way that our data. So I'm a statistics person, and life expectancy, the way that we calculate life expectancy, is very convoluted. And so it's, Kate, I'm probably going to need your help because I should have spent a little bit more time going back to the textbook, but the life expectancy is really a projection, and it's a way of accounting for the many factors that can impact the patient's, the baby's health in the future. And so that new projection was done prior to the vaccine being released. And so it would be important to know what the life expectancy would be, the new calculation next year. But that the numbers that I showed were calculated prior to the vaccine being readily available in our population.
Yeah, I agree. I agree with you. The life expectancy changes based on what things we see now. So the life expectancy calculated pre-vaccine is going to be completely different from the life expectancy post-vaccine. Next question. Black women are 3 times more likely to die from pregnancy-related causes than white women. It's been estimated that a significant portion of these deaths could be prevented. What are healthcare providers doing to address this issue?
So maternal mortality is one of those areas that we're definitely trying to work harder to overcome. As a Black woman, it terrifies me that my life, that I have a risk, much higher risk of dying, irregardless of my higher social economic status. So we know that a Black woman, college educated Black woman, still has a 2 to 3 times higher risk of dying during pregnancy than a white woman with a high school education. So one of the things that we're working to do is to increase bias training within the healthcare system. But we also know that we need to use data and evaluate what are those drivers of health inequities. And so I didn't include the slide here, but we know that it's not just a poof, health inequities occur, but we know that there are differences in care that can cause differences in health outcomes. So we need to study more those differences, evaluate those differences more closely, and use data to measure those differences, not only in health outcomes, but the care that is provided to patients. And so a lot of systems are working on that, and also identifying when there are significant differences among providers in the care that they give to patients. So those are 2 things that we're doing, improving training for bias, but also using data to help us to evaluate the larger system differences as well as the provider differences in treatment that could be impacting the health outcomes of patients.
Thank you. Next question, I'm going to let Rhonda ask her question. Rhonda, why don't you go ahead and unmute yourself?
I think you're muted now, Rhonda. Did you freeze?
Oh, I hear, I think.
Thank you. That was a great presentation. But
Oh.
I would like to say, I can have so many questions tonight, but I'm gonna keep it simple. I worked as a GME coordinator in 2 hospitals, and I know that racism is in as far as medical school, the residency program. So my question to you is, this presentation that you presented, is it being discussed at that level in medical school when you do your residency? You know, before you become that doctor who's working.
It actually is. So the question is, do we teach trainees in medical school and residency about racism? The good thing, and I'm bragging on the millennials because I'm a millennial, we know that millennials, younger doctors, typically because the world has been more diverse since we've been going to school, that we're typically less likely to be biased and have those differences, those thoughts. And so we're doing a good job of training the younger generation, but much more needs to be done to the doctors and nurses that we're training a lot longer. As I mentioned, hospitals have recently been integrated. The 1960s is not a long time ago. So there are some doctors that have been practicing since then. And it's not just those doctors, but imagine they trained other doctors as well. And so we've been doing a really good job with training the trainees, but more needs to be done there, as well as addressing the biases and the education and training for more senior doctors as well.
Thank you, Dr. Lee. That was the last question.
Can I ask one more question?
Yeah, absolutely. Just go slowly, Rhonda, because you're going in and out.
Oh, okay. I just want to say too that when it comes to when I guess when the trainees are getting ready to start a residency and you have to do that match, there's a lot of racism in that area as well. So I'm just so proud of Dr. Nevin for recognizing these things and, you know, beginning to do something about it.
I agree. Thank you, Rhonda. Your point is well taken. We know that there are many barriers to increasing the diversity in the health workforce. I'm a mentor. We have a training program, a few training programs to increase the number of minority students from underrepresented backgrounds, underrepresented minorities, increasing the number of students in the pipeline, because we know that there are a number of barriers that students from underrepresented backgrounds face when they try to become a doctor. We know that there are financial barriers. It takes a lot of money to prepare for the tests that you have to take. But we also know that unfortunately, there is some of that individual level racism and biases that can impact admission boards and councils when they're selecting students for medical school and racism. So definitely as an institution, we have made that our priority, and we're working on many levels to increase the number of students pursuing STEM careers, as well as the number of minority physicians that work at Christiana Care and care for our patients. So thank you for that question.
Well, thank you, Dr. Lee. There don't appear to be any more questions in the chat, but there is a lot of thank yous and appreciativeness for you coming in. I want to say one more time for those that came in late and missed my beginning spiel, please make sure that you fill out any survey that you got from me today. You either got one from me this morning saying I don't have you down as being here for 5 sessions. Everybody's going to get one from me tonight at about 8:45 saying, please fill this out for today. The surveys will close at 11:59 on Sunday, May 23rd p.m. Right? After that, I will not be accepting any more surveys. And if you haven't filled out the survey, then you won't get credit for being in the class and you will not get your certificate. So if you want that certificate, make sure that you fill out any surveys that I sent you. Thank you very much. That's the last time I'll get up on that soapbox, but that's the most fair way that I can do it so that those who have come will get a survey and those who haven't come to all of them will not. So thank you, thank you. And watching it online counts, watching it on your phone counts, watching it on Zoom counts, but I need to know, and I need to know by Sunday. So thank you for coming. And I'm done. Tim, it's all you.
Well, Dr. Lee, thank you so very much. And Dr. Smith, thank you for your leadership of the class. And I just wanted to remind everybody of some takeaways that you can do right now, especially if you are not a person of color. Be aware of your own prejudices. Educate yourself. Talk with children and youth, or if you are a child or youth or a student, talk with others, talk with your teachers, talk with your parents. Speak up when you hear something, show up in person. If it's to a game, to a rally, to a special event, be present there. Be a healing presence. It's not enough to just internally feel like, ooh, this is something I'm going to do better with you. You really need to project that. Be a witness. If you see something, say something. If you see a good act, compliment the person on it. For racism, of course, also has language components to it. Tutor an English learner. And finally, tell your elected officials, tell the principal at school that this is something that you care about. Those are real world things that we can and should be doing right now. Thank you all for attending Mini Medical School, not only tonight, but all the other sessions. And we'll see you again next year. Take care. Good night.